Students, next class of drugs that is used for the treatment of hypertension are very widely used, and specifically in Pakistan they are most widely used. Beta blockers. So beta blockers, if used alone in mild to moderate hypertension, why these are used in hypertension? Because beta receptors are present on the heart. So beta 1 receptors are present on heart. So once these receptors are activated by norepinephrine, these increase the pacemaker depolarization. So pacemaker depolarization means SA node depolarization is increased and increase the firing rate of SA node. So thereby they increase heart rate. So once the heart rate is increased, so it will increase cardiac output, and cardiac output is increased and it will increase hypertension. There is a chronic resetting of this all mechanism, which increases and which causes hypertension. So hypertension, so we use beta blockers. So beta blockers are used to block beta receptors. Here is a drug. This cross depicts a drug. It blocks the beta receptors, so thereby norepinephrine cannot bind with this beta receptor, beta 1 receptor, and it will decrease heart rate and decrease cardiac output and will treat hypertension. So that is why beta blockers are used in hypertension. These are used alone or in mild to moderate hypertension, while in severe hypertension used in combination with direct vasodilators to counteract reflex tachycardia caused by them. Okay, now there are two statements for the usage of beta blockers. Either beta blockers can be used alone or in combination. So when using alone, they are used in mild to moderate, like stage 1 hypertension, but in severe hypertension or stage 2 hypertension, we need more drugs like vasodilators or direct vasodilators. We have to, if we have to use vasodilators excessively dilate vessels. Once vessels are dilated, the body actually feels that excessive blood pressure has dropped down. So they increase heart rate in response to vasodilation. So that is why it is called reflex tachycardia. Reflex tachycardia is in response to vasodilation. So if vasodilators or direct vasodilators are used, it often causes reflex tachycardia. And what is tachycardia? It is increased heart rate. Heart rate is more than 100. And reflex means it is in response to the use of vasodilators. So thereby, if beta blockers are used for severe hypertension, they are used with direct vasodilators to counteract or to combat the reflex tachycardia. Then we have individual drugs like propranolol. Propranolol blocks both beta 1 and beta 2 receptor. Beta 2 receptors are present in lungs, while beta 1 on heart. Propranolol decreases cardiac output and principally by reducing vasoconstriction. While so propranolol is also called as non-selective beta blocker, because it non-selectively blocks both beta 1 and beta 2, while metoprolol and atenolol blocks only beta 1 receptors. These are also called, while beta 1 receptors are present on heart or cardiac muscles. These are also called cardioselective beta 1. So cardioselective means beta 1 receptors that are present on the cardiac tissue, and most widely used in hypertension. Decreased cardiac output and peripheral vascular resistance, contributing to decrease in. So what is their role in decreasing blood pressure is decreased cardiac output and peripheral vascular resistance. Labetalol, carvedilol, and nebivolol. So beta blocker receptors, these block beta receptors and induce vasodilating effects. Then we have another very important class, alpha 1 blockers. These are not widely used for hypertension, but the other indications are there. These include prazosin, terazosin, and doxazosin. So block alpha 1 receptors. The location of alpha 1 receptor is in the arteriole, and their function is to cause vasoconstriction. So vasoconstriction is done by alpha 1. So if you block these receptors, so this vasoconstriction can be corrected, and this is done by these drugs, prazosin, terazosin, and doxazosin. These drugs produce less reflex tachycardia as compared to non-selective alpha antagonists such as phentolamine, salt and water retention when used without diuretics. And their major side effect is first dose effect or postural hypotension, which is also called orthostatic hypotension. It's one and the same thing. Postural hypotension or orthostatic hypotension. If you change your position, your blood pressure drops down quickly. So these are also vasodilators. These actually dilate vessels by blocking alpha 1 receptors. So they have an effect to effect on pooling of blood. So if someone abruptly changes position from lying or from sitting to standing, so the blood is already pooled in their vessels, so it can cause dizziness, and they can fall by spontaneously lowering the blood pressure. So this is also called first dose effect. So their minimum dose is administered at the night time to prevent this first. Once the body is accustomed, then the dose is titrated up. Then we have vasodilators like hydralazine and minoxidil. They act by different mechanisms like minoxidil. Minoxidil spray is available for the hair growth, and it was initially developed as an antihypertensive, but its side effect superseded its indication. So it results from the opening of potassium channels in smooth muscles, and increased potassium permeability stabilizes the membrane and its resting potential and less likely to cause contraction. Then we have inhibitors of angiotensin aldosterone system. So renin angiotensin aldosterone system, first we have to take an overview that what actually this does in normal physiology. Renin angiotensin aldosterone system is a very beautiful or a beautifully articulated system, and it involves multiple of organs, for example liver, for example kidney and lungs, and then again kidney, vessels, then it involves ACEIS secretion as well. So all this combine the renin angiotensin aldosterone system. So the start or the beginning of this is due to decrease in blood pressure or sodium content. Sodium content of the blood flowing through kidney. Once the blood reaches to juxtaglomerular apparatus and it is low in sodium content, so body thinks that blood pressure is lowered. So body releases renin. And renin is circulated in the blood. Then in liver there is a protein, angiotensinogen. Renin actually is an enzyme which catalyzes this protein and converts it into angiotensin I. So angiotensinogen released from liver is acted upon by renin, that is released from kidney, and it is converted into angiotensin I. Then angiotensin I circulates through lungs, and there is an enzyme, surface of pulmonary and renal endothelium, called ACE. This is angiotensin. So this is angiotensin converting enzyme. So it converts the angiotensin into angiotensin II. Angiotensin I is converted into angiotensin II. So this is ACE. So angiotensin converting enzyme is acts at this site, and once the angiotensin II is formed, angiotensin II has multiple effects. What are these effects? These can be related to different sites and different effects. The angiotensin II has a rapid pressure response. Rapid pressure response means it increases blood pressure rapidly. So it does it by direct vasoconstriction, enhancement of peripheral norepinephrine or noradrenergic neurotransmission, increased sympathetic discharge. Here you can see this increases the angiotensin II, increases sympathetic activity. This sympathetic activity actually causes many effects. This can cause release of ADH. ADH, anti-diuretic hormone. So once the ADH is released, it will cause retention of water and it will cause absorption of water, and this will again cause increased reabsorption. It will release tubular sodium and chloride reabsorption and potassium through acting at adrenal cortex. So angiotensin II will act on adrenal cortex. It will release aldosterone secretion. Aldosterone once released will cause sodium and chloride reabsorption and potassium excretion and water retention. So water retention at two sites in kidney is occurring. So sodium is reabsorbed, potassium is coming out, chloride is reabsorbed, water is absorbed. So ultimate goal is to increase water. So sympathetic activity will increase vasoconstriction, then arteriolar vasoconstriction increases in blood pressure. So remember that all of this started because there was a decrease in blood pressure in normal physiology. So it raises the blood pressure, and ultimately this has many effects. So why do we use these drugs? Because there is a false set point is set which actually releases renin, which due to nephrons which releases renin on a continuous basis. So what we do, we block this system on many instances. The first is ACE inhibitors. ACE inhibitors are ramipril, enalapril, quinapril. So ACE inhibitors actually block this system at this level. So angiotensin 1 will not be converted into angiotensin 2 and all these effects won't be produced. So ACE inhibitors increase bradykinin levels, and bradykinin stimulates prostaglandin biosynthesis, and these contribute to their pharmacological effect. How blood pressure is decreased? It lowers systemic vascular resistance, mean diastolic and systolic blood pressure, systemic arterial dilation, and then there are pharmacokinetics of these drugs. Therapeutic uses. Therapeutic uses, these are used in severe hypertension, congestive heart failure, left ventricular systolic dysfunction. ACE inhibitors in acute myocardial infarction can increase or can have a beneficial effects. Then we have adverse reactions to ACE inhibitors. Hypotension, cough, a dry cough. If some patient, a hypertensive patient, comes to you and complains about a dry cough, just check with that patient that if that patient is using ACE inhibitors or not. So almost 5 to 20% of patients. Hyperkalemia. So in patients with renal insufficiency or patients taking potassium sparing diuretics, potassium supplements, beta adrenergic receptor antagonists or NSAIDs, hyperkalemia is an increase. And then we have skin rash. This can range from maculopapular rash that may be pruritic, they may be itchy and filled with pus. Acute renal failure, they constrict efferent arteriole. Angiotensin II help to maintain adequate filtration when renal perfusion pressure is low. So consequently, ACE inhibition can induce acute renal insufficiency in patient with bilateral renal artery stenosis. What does it mean? It means that if a patient is having a bilateral renal artery stenosis or is suffering from both the arteries are already blocked, in these patients acute renal failure can occur. Angioedema or the facial edema or larynx, lips or tongue, this untoward effect is called angioedema. Almost 0.1 to 0.5% of patients suffer through this. Then we have angiotensin II blockers. ARBs, these are also called ARBs or angiotensin receptor blockers. So if you do not block angiotensin II at this site here, then you can stop angiotensin II for making a bond with the receptors. So these drugs actually inhibit most of the following biological effects of angiotensin II by blocking angiotensin II receptor binding. They are the contraction of vascular smooth muscles of vessels like vessels. So vessels will not be constricted, it will decrease peripheral vascular resistance. Both rapid and slow pressure responses, thirst, vasopressin release, aldosterone secretion, release of adrenal catecholamines, enhancement of noradrenergic neurotransmission, changes in renal function, cellular hypertrophy. So most of the effects of angiotensin II are blocked. So thereby they can be used in hypertension. So therapeutic uses are approved for the treatment of hypertension. Irbesartan and losartan are approved for diabetic nephropathy. Losartan is approved for stroke prophylaxis, and valsartan is approved for heart failure patients who are intolerant to ACE inhibitors. And talking about the side effects, angioedema with ARBs is much less than with ACE inhibitors. ARBs have teratogenic potential and should be discontinued before the second trimester of pregnancy. Teratogenic means that it can cause defects in the fetus. ARBs may cause hyperkalemia in patients with renal disease or taking potassium supplements, and ARBs or angiotensin receptor blockers should be cautiously used in patients whose blood pressure or renal function is highly dependent on renin-angiotensin system. So there are certain patients whose system is dependent on renin-angiotensin system. For example, renal artery stenosis. So renin is released and their maintenance of their glomerular filtration rate is done by renin. So in these patients, hypotension, oliguria, and progressive azotemia or actual renal or acute renal failure may occur. Thank you very much.